I find when we are dealing with scheduling, dealing with either nurses or techs, trying to fit things in within the hospital resources, there's a lot of questions as to, oh, we're treating this now, we weren't treating this 3 years ago. Why is that? And the reality of it is that we have to go back and explain that the tools are so good now to take out thrombus that we are able to be aggressive and take out as much thrombus on a lot of these patients when it's clinically indicated. And we know that from experience, at least, and some data that we're going to get into, that PTS rates and long-term sequelae are far improved when we do treat these patients.
And importantly, the risk is practically mitigated. There's no risk of bleeding, right? I mean, there really isn't those inherent risks of lytic therapy that you're always like, it's relative contraindication, absolute contraindication. Those are the real worries. Efficacy is, of course, very, very important, but safety is even more important. And I think now that we don't worry about primarily using lytic-based therapies, that allows us a little bit more courage to be more aggressive.